Hey, everybody, welcome back to the Monday Afternoon Journal Club. Ed Bowder and Dan Schwester here with you from the Overrun. Danny, today we have a study that is coming out of Brazil with some contributions from our friends at the Mayo Clinic. This is Peri-Intubation Adverse Events and Clinical Outcomes in Emergency Department Patients. This is the BARCO study. This is done by Maya et al., and this is a really, really interesting analysis that they did. So this is an ER study, right? And we've talked about the differences between ER studies and pre-hospital studies. What they did here was they did a prospective cohort study of 18 emergency departments in Brazil. This had 2,846 patients, which is a pretty decent N. And the big picture that they came up with, 1 in 3 patients undergoing emergency intubation experienced a major peri-intubation adverse event, which is associated with a higher 28-day mortality. So Dan, here in this study, what we see is most of the adverse events were hemodynamic instability and then hypoxemia, and then cardiac arrest was in about 3% of the group. 28-day mortality is 45%. So just looking at this, like, all right, half the people we intubate are going to have a high 28-day mortality, and a third of the patients are going to have adverse events. That's not super encouraging.
It's not. And it reinforces that we have to be very, very serious about preventing these events from happening. When you've got a procedure that you have to do on somebody with a 45% mortality, that's scary. That's something that really, really should be drilled into our heads. All the things that we've learned in the last 10 to 15 years, right? Pre-oxygenation, resuscitate before you intubate, bundles of care, use of pressors and aggressive use of pressors. Hypoxemia and hypotension kill your intubated patients. We have to do everything possible to avoid it. And if your place doesn't do these things, you might not need to intubate, or you shouldn't be intubating.
No, and that's probably right. And I think that when we first started doing RSI, when it came to the pre-hospital arena, when it became the big new sexy thing, it was kind of like, you know what, now we can do this. So you have a patient, knock them down, tube them, great, be on your way. And then we started finding out, like, all right, well, it turns out when you paralyze people and you relax all of their skeletal muscles, all the vasculature relaxes as well, and we dump their pressure. So over the past 15 years, it kind of feels like we've been building up toward whatever the next thing is, right? Whether we're going to build out from RSI into a new technique, but RSI has really kind of become the technique, right? We've had some finer point debates over, maybe we add ketamine, how do we, work fentanyl into it and all that. But in the end, we're still performing this kind of dangerous procedure on all of these people who already have all of these health issues that have led them to need to be intubated.
Absolutely, Ed. And that just reinforces that if we're in a situation where we have to do this procedure, we owe it to the patients to do it safely as possible. We're not going to always take away, and this rate is not going to go down to zero. Okay. People are just too sick. And a lot of times when we find people in the field that need an airway, they're in extremis. However, when we, and you mentioned when we talked about when we started RSI, we saw this a lot. And I liken this whole thing with intubation, especially emergent and pre-hospital. This is the Dunning-Kruger curve. For the places we got RSI, we were at the peak of Mount Stupid. We had these tools. We were going to tube people. We were going to do great. And then we hit the valley of despair because these people were dying and we didn't know why. And it was really humbling and it was upsetting. And we had to learn how to do it better. And now we know how to do it better. And we can reduce these incidences. We're still seeing way too much hypoxemia when we've got things like high flow nasal cannulas and, the pre-oxy study with, using a CPAP mask and tight fitting seals and increasing denitrogenation, 100% oxygenation, use of pressors, being aggressive with your pressors. We always draw a push dose when we do this. I'm almost starting to think that it might be better to start a prophylactic epi drip at a low rate or a norepi drip to maintain circulation during this procedure. You can always titrate it down. You can always titrate it off. But it seems that once we get these people calmed down and ready to intubate, this is when the bad stuff happens. And we have to be aware of it. We have to be prepared for it. And yes, that means it's going to take a few minutes on scene. But if it's worth putting in the airway, it's worth doing it right.
Right. And we did talk to Eddie Gutierrez on the podcast about this, about which pressors to have. And his answer was essentially whatever you have.
Mhm.
So, we can have the academic debate of whether we use epinephrine or norepinephrine, phenylephrine, all these variables, whether we use an alpha drug, a beta drug, an alpha and beta drug. But I think the overriding point here is, and again, this study came out in April of this year. So this is out on April 17th, 2025. The issue is that this is still happening. And again, this is out of Brazil. So there's going to be people saying like, well, this, if you've seen one system, you've seen one system. We've said that a million times. But I think it's kind of representative of the example of we're still intubating very quickly without resuscitating first. So I see this study and I see the biggest thing, 20%. So 1 in 5 are going to have hemodynamic instability. In the field, if I have someone who I'm going to RSI, you have to start a bag of fluid on them to try and increase your preload. You have to have some kind of pressor available to you, at least. Having the pressor available and not using it, fine. I'd rather have it and not use it. The old adage of like, I'd rather have it, not need it, than need it and not have it. So, you go into your RSI procedure, you get your pressor, you get whatever fluid to increase your preload, and adding that to the bundle of whatever paralytic, whatever sedative you have, I think is probably the smart way to go. We've heard the adage of resuscitate before intubating for 10 years now. And now it's something that it seems to be kind of data backed. So this new batch, right? The new bundle that you should be getting going into an RSI procedure is your fluids, you have your pressor, you have your high flow nasal cannula, you have whatever oxygenating tools you need, and you have your intubation supplies, and you have your backup airway, and you have your cric kit. And you want to have all that kind of laid out to plan your RSI in a stepwise procedure, right? Where
Mhm.
all right, I
Sure.
can't intubate my patient because they're hypoxic. Great. Put them on a high flow nasal cannula, get that oxygen level up. Well, now the problem is that they're hemodynamically unstable. Great. Give them fluid, give them a pressor. All right. Well, now the problem is that I can't intubate them. Great. Give them an LMA, give them an iGel, give them whatever. Well, I can't pass that. Okay. Well, now we're going to cric them.
Mhm.
Right. And it's very easy to kind of illustrate this procedure as super, super difficult with a lot of things that can go wrong. It is, and they can, but we can kind of mitigate a lot of those risks by just preparing. So I don't know that this study tells us anything that is particularly new, right, to our world of information. I think we're aware that RSIs cause hemodynamic instability, RSIs cause hypoxemia, RSIs cause cardiac arrest. But knowing that this has been established in the literature, great. Now we can establish bundles where, like, I'm going to stop. The first problem is hypoxemia or hypotension. Great. I'm going to give them fluid. I'm going to give them pressors. My second problem is hypoxemia. I'm going to keep them well oxygenated. And we can start kind of hammering down these problems where, eventually the problem with RSI is that whatever 3 days later they develop sepsis because the tube we used or the needles we used weren't entirely sterile in the field. So we have these problems. We know that we can fix them now. And these are things that we can kind of implement in our EMS systems. We can increase patients' blood pressure. We can increase their oxygenation. It's all stuff we need to do in the field.
We have to be much more protective of our patients. We have to stop looking at this as an ego procedure and looking at it as, listen, this has to be done. It has to be done correctly, and it has to be done with an eye toward physiology. And if you're not doing that and your place isn't doing it for you, you shouldn't be doing this.
Yeah, and you haven't failed your patients if you don't actually successfully intubate the patients. The only way you're failing your patients is by not doing the procedure in the first place. Do it effectively, do it safely, and let us know what you guys think. If you've read this BARCO study, or if you're even from the consortium down in Brazil that's writing it, please let us know what you guys think. Subscribe down below, click the bell for all the new updates. Check us out on EMS One and follow the Overrun podcast. And from the Monday Afternoon Journal Club, Ed Bowder, Dan Schwester, and we'll talk to you all next week.